we have nothing to disclose. Quite a large number of patients complain of overactive bladder after artificial sphincter. And furthermore, some patients are refractory to medical treatment. Medication refractory overactive bladder is a frustrating situation both for patient and urologist. Then, which patients have the possibility to be suffered by medication refractory overactive bladder? There is little information available. So, we have investigated the prevalence, patient characteristics of medication refractory overactive bladder. We have included only the patient who underwent radical prostatectomy for prostate cancer. Medication refractory overactive bladder was defined when the overactive bladder symptom score evaluated during the medication corresponds to the criteria of overactive bladder. Out of 132 patients, about 16 patients were refractory to medical treatment. We regarded that the overactive bladder noted within 1 year after surgery is likely affected the surgical procedure and grouped the patient into early and late onset overactive bladder. The patient who had preoperative involuntary detrus contraction or the patient who had a small cystometric capacity was prevalent in early onset overactive bladder. The medication response was evaluated among the patients who received medication for more than 3 months. The duration of medication was significantly longer in medication refractory group. From this result, we may suggest that the lack of response to treatment is not for the insufficient treatment, but for the patient intrinsic factor. In early onset overactive bladder, the patient who had preoperative involuntary detrus contraction was prevalently higher in the medication refractory group. And the history of intracranial vessel disease had a slight tendency toward significance. In late onset overactive bladder, the medication regimen was significantly different from the groups, showing the combination regimen prevalence in refractory group. We think this result is not for the poor efficacy of combination regimen, but for the patient intrinsic problem. Therefore, we might conclude, as after artificial sphincter, about 16% of patients were refractory to medication treatment. And the patient who had preoperative involuntary detrus contraction have the probability to be refractory to medical treatment. Therefore, the development of third-line therapy targeted on the involuntary detrus contraction might be useful in management of medication refractory overactive bladder. Thank you.
Hi, Peter is here from Utrecht, the Netherlands. I don't think it's surprising that the symptom of urinary incontinence has a variety of pathophysiology as a background. Also in men after radical prostatectomy. And as you've shown, and I correct your terminology, some of your patients had overactive detrusor before your implantation of the sphincter. And I'm not aware of any evidence that cures detrusor overactivity. So would you consider detrusor overactivity before sphincter implantation a contraindication for sphincter implantation? Or would you consider to treat patients before implantation and see whether medical treatment solves the problem without any sphincter implantation?
Yes, you can observe very poor surgical outcome in patients who had preoperative involuntary distress contraction. So last year we have already presented that the poor surgical outcome related with urgency urinary incontinence and postoperative overactive, etc. That patient population is different from this study, and we might suggest with cure that involuntary distress contraction might related with poor surgical outcome regarding the lower urinary tract symptoms.
So preoperative good diagnosis is extremely relevant. We agree, I think. With regard to your cystometry, what did you do? You filled up the bladder until leakage?
Yes, fill the bladder until leakage. And we usually, for the patient with post-prostatectomy incontinence, we do not, we do set of the study without clamping and with clamping. However, in this study, we have only without clamping data is included in this study.
I couldn't agree more. I think this should be the standard technique. So urodynamics should not be done to show incontinence. It should be done to show the cause of incontinence and to show what will be the situation if we correct urine loss. And excellent. Thank you.
Thank you.
I want to know from the audience, how many people perform urodynamics before, during surgery for urinary incontinence after radical prostatectomy? Who does not? What do the guidelines say, Peter?
No, there's no guideline for this. And I'm certainly going to write it. If someone wants to join me, just send me an email. But what's in the literature is that everyone says, okay, fill up the bladder and show the incontinence. And then some say, okay, it's low pressure incontinence or large volume incontinence, and we think that we know everything. But filling up beyond the incontinence, sometimes you can fill 10 mLs and they start leaking when they are sitting. So, and they can tell you, I cannot hold anything in the bladder apart only in the night, and that would be a good sign. But preventing the incontinence during the cystometry, there's no prospective evidence. However, we all are aware of pathology of pathophysiology of urinary incontinence, and some have good bladders. You fill them up until 400, 500, and you will know that everything's okay. But some have bad compliance, ditterous overactivity at small capacity, at large capacity, and you can counsel the patient, and maybe a prospective study will show that pre-treatment will help in some and will help prevent your problems after the sphincter implantation. But that all should be a prospective study. I can speculate on that and talk about this the rest of the day, but it should be confirmed in prospective studies.
Thank you very much. One more remark, please.
Even though we don't have consensus, as Peter said to us, we recently, our group made a revision of the literature, and it was nice because we saw that maybe 6 or 65% of the papers use urodynamics in all cases, about 20% of the papers in selected cases, and only 10 to 15% no urodynamics. So even though no consensus, most people are performing, as we can see here today. Thank you.
Thank you for that. I think it's very important, Peter, that if we do urodynamics, we should do it in a proper way, also in this group of patients, because I think that quite often the information that we want will not be provided by the urodynamics because of the way it is done. Okay, thank you very much. Thank you, Dr. Son. Thank you.
Let's move the